Colonel Rob Maness has a lifelong record of providing dedicated service to this nation. Having worked his way up from the enlisted ranks to full colonel, he served our country for more than 32 years. He has served as a bomber squadron commander, bomb disposal technician, Joint Chiefs of Staff Operations Officer, assisted the National Security Team with the campaign plan for the global war on terrorism. He authored the first theater nuclear war plan and served as the Vice Commander of America's largest airborne intelligence wing. Colonel Rob Maness is a true American hero. This is Rob Maness Live.
We had several new dialysis patients admitted to our clinic who had been hospitalized with COVID. And they were told in the hospital that COVID had shut down their kidneys. But by that time, I was pretty savvy and I knew what was happening. They were getting remdesivir, the drug that some nurses call run, death is near, and that was shutting down their kidneys.
COVID itself is not a kidney disease, but remdesivir causes kidney failure. In animal trials, a third of animals receiving remdesivir had kidney failure and then organ failure.
My patients seemed to decline after remdesivir, especially after more than 2 doses.
They all ended up with kidney failure within a few days.
So were you with her when she died?
In the last 15 minutes. They finally let me in the last 15 minutes. My mom was beautiful. She was 6 feet tall. She was about 180 pounds, redhead, curly hair, vibrant. And then when I got there, she had been completely stripped of all her dignity. Her hair was matted. She was laying in her mess. If I had been there with her, I would have taken care of all of that. I would have stayed with her in the hospital the entire time.
In viral illnesses, you want to start an antiviral as soon as possible upon first symptoms, within the first day or 2 or 3. We knew that people who entered the hospital, typically around day 7 or 8, there was this viral replicative phase, and then there was this inflammatory phase that ensued.
Think of it. Most people got to the hospital usually day 7 to 8 in their disease. That's when the virus has essentially stopped replicating.
And I've been taught in my undergrad, my bachelor's degree program for nursing, that you do not administer an antiviral more than 24 to 48 hours post-symptom onset for a viral infection. This medication was being given to patients who were hospitalized with COVID, usually not until between 10 and 12 days post-symptom onset.
So it had no rational, logical sense to use a very expensive, somewhat toxic intravenous medicine for days at a time when there's no live virus, when it's an inflammatory condition. So just based on logic, it made no sense.
We have evidence.
Run. Death is near. The Remdesivir papers. Welcome to Whistleblower Wednesday on the Rob Maness Show, and we're live on Worldview Tube and our X Spaces simulcast. Well, did the Department of Defense collude with Big Pharma to experiment on unsuspecting military service members and veterans using the drug Remdesivir? A military whistleblower has come forward to offer evidence that 64% of service members and veterans whose deaths were attributed to COVID-19 were also administered Remdesivir, a drug with a known lethal past, publishing the information in a report titled the Remdesivir Papers last week. The data in the report clearly shows a very widespread use of Remdesivir in military treatment facilities and other civilian facilities, as well as its potential contribution to, at a minimum, hundreds of untimely deaths between 2020 and 2024, according to a WorldNet Daily report from J.M. Phelps, who also writes for the Gateway Pundit and has published about this report there initially. My guest today to dive into the Remdesivir Papers report is former U.S. Army Lieutenant Colonel Brad Miller, who was relieved of his battalion command when the 101st Airborne Division for refusing the COVID vaccine under the unlawful direction of Defense Secretary Lloyd Austin's now rescinded August 2021 shot mandate, and Dr. Chrisanna Shackelford, a leading advocate for service members and veterans affected by vaccine-related injuries, with a deep commitment to uncovering the truth about how military personnel have been systematically harmed and disenfranchised. her investigative research and collaboration with a VA whistleblower into the lack of accountability and transparency within the VA, imagine that, has revealed troubling trends in how the VA dismisses vaccine injuries, particularly within the military. Brad and Dr. Shackelford, welcome to the Rob Maness Show.
Hey, thanks so much for having me back on. Great to see you again. Happy to be here.
And likewise,
great to have you on. Thanks for coming on, guys. We like to do a panel every once in a while. This is a great opportunity. I guess my first question to both of you, starting with Brad, is give the audience the big picture of what you see from this report, and then we can dive into some of the details, because there are some horrendous details here.
Yeah, so I think there's a couple of places that we can start at. So first and foremost, you mentioned that this was published under the name the Remdesivir Papers, and this was co-authored by a journalist, that's J.M. Phelps, and then also he was assisted by a gentleman, goes by the pseudonym Daniel LeMay, I believe, which is, this is a whistleblower from somewhere within DOD. So I don't know the identity of the whistleblower or exactly what this individual's position would be somewhere in DOD. I don't even necessarily know that it's a gentleman, except I'm just taking that from the name of the pseudonym used. But this was the result of collaboration between this whistleblower and J.M. Phelps. And of course, this was originally published October 4th. So this was less than a week ago under the name the Remdesivir Papers. And what this does is it basically shows that there are a lot of questions that both the military community and the wider public should be asking about the use of remdesivir as a therapeutic for those who ostensibly have had.
Dr. Shackelford, what's your overall view on this report?
So I'm going to take a higher level view first and just basically frame this entire discussion about the fact that the military, particularly service members, have been extensively used in clinical trials. This is a big issue. We know that they have used our enlisted service women in vaccine clinical trials. Of course, we have this particular remdesivir discussion. And I think at some point during this discussion, we're going to add the fact that this particular product, if you will, had a 53% mortality rate during the Ebola trials. In fact, they tried 4 particular medications, if you will, and vaccines during the Ebola crisis, and they ruled out 2, one of which was remdesivir. So fast forward to this particular discussion, I think it's particularly apropos to, number one, ask the question again, is the Department of Defense actively, if you will, mandating toxic exposures? And why aren't we discussing this more broadly when we see that service members are being recruited? In this particular case, clinical trials, I think there was something like 23 particular sites that were being used. And we have no insights as to whether or not they were provided informed consent. Did they understand the toxicity of this product? Did they understand the death rate of this particular product? So this is a much, much bigger deal. And the issue surrounding SecDef's decisions to provide mandates and to allow and let service members be used during clinical trials.
Yeah, it's, with the numbers, 601 deaths that we know of in these trials. That leads me to a very specific question that I have, Brad, and you can take it first, is, it appears that according to the papers that DOD started liberally using remdesivir 5 months before it was approved as an emergency use authorization drug and 7 months before it was fully approved by the FDA, and that they were in a contract with a big pharma company called Gilead. Well, let's take that apart. So how does DOD get the opportunity or get authorized to use a drug in clinical trials on military service people and veterans around the world, even in the war zone in Afghanistan? If I read the Dr. Shackelford's latest article correctly, without even an emergency use authorization. What is going on with that?
Yeah, so let's go back to 2020 when most of us were probably just hearing about COVID for the first time in early 2020. You mentioned before the company Gilead, which is responsible for the production of remdesivir. People may know that there's a relationship there between the Bill and Melinda Gates Foundation and, of course, that company Gilead. That's true. They have some ownership or at least investments in the company pretty significantly. And we do know, and this is in the remdesivir papers, that between the time period of March of 2020 and March of 2024, so a 4-year period, there was the administration of remdesivir to individuals within the military community. And there is a table of data that we have from this whistleblower, which is included in the publication, that says that during that time period, there were 941 individuals who were administered remdesivir, and of that, 601 died, which is about 64%. Now, what does that data mean within a wider scope? Well, also in the remdesivir papers, we are told about 5 different trials on remdesivir that happened, clinical trials. 4 of those were sponsored by the NIAID, which is the National Institute of Allergies and Infectious Diseases. Many people will know that that is led by Dr. Anthony Fauci. So 4 clinical trials that were sponsored by NIAID. These were phase 3 trials, which means they were conducted to determine the efficacy of a treatment like remdesivir. But there was also a 5th trial. And there was a 5th trial that we know about that was sponsored by the United States Army Medical and Research and Development Command out of Fort Detrick. And for that trial, we have no data. So if you go to the remdesivir papers, which I would encourage all those who are curious or even skeptical about this topic, I would encourage everyone to go and check this out. You will see tables of data from these trials that are presented. And you will see the tables giving the results from the 4 NIAID-sponsored trials. And you will also see a table with no data from the 5th trial, which was sponsored by the Army, this Medical and Research and Development Command out of Fort Detrick. And so we know that that phase 3 clinical trial took place. We know that it was sponsored by the military, but we don't have any data for it. So why don't we necessarily have any data for it? So the 4 trials that were sponsored by NIAID, even they are quite problematic. It seems to be that there are questions about the use of placebos, which placebos were used, were true placebos used. There are also questions about participants and all the enrollees and whether or not they made it to the end of the trials. Now, this is significant because a lot of claims have been made over the last couple of years about remdesivir use in trials, stating that those who are conducting the trials are moving the end posts, or in other words, they're moving the end point of the trial, or moving the goalposts. Mm-hmm. And what that means is that the stated end point of the trial throughout the conduct of the trial is changed. Now, why is it changed? Is something happening in the trial that those who are conducting the trial do not necessarily want to have to put into the results, and so they have to end up truncating the trial so that in a way that may skew the data to make remdesivir look more favorable as a treatment protocol? These are the questions that we should be asking. So we have the data that comes from these 4 NIAID-sponsored trials, in which there are many questions, and at least some of the questions lead us to believe, hey, was the trial skewed in a way that was unscientifically rigorous in order to make remdesivir look like a more favorable treatment protocol? And then we take that, and then we look at this 5th trial sponsored by the military, in which we have no data, but we know it was conducted. And then we have the whistleblower come forth and show us this 4-year data, which says, hey, 64% of those who were administered remdesivir died. So we're left with more questions than answers. And so when we look at everything else that has happened over the last couple of years with COVID-19, I think that the intellectually curious person, whether they're in the military community or just the wider public, is going to say, hey, what's going on here? And are they hiding something from us?
Absolutely right. Well, we got to take a break here. When we come back, Dr. Shackerfold, we'll put up the chart that shows those death numbers, and because it's pretty horrendous. And I want to give you an opportunity to speak to what these numbers mean from an overall population perspective, because this drug is deadly, as you mentioned before in the Ebola trials, 53.1% fatality rate, regardless of the virus load that the human beings that were given it were were experiencing at the time. So we'll be right back on the Rob Maness Show, and we're talking Whistleblower Wednesday, the Remdesivir papers. Run. Death is near is what a lot of the nurses call it.
We live in uncertain times. In fact, we live at a time when our own governments all over the world are warning us that there could be big problems with our power grid. World War III seems to be right on the horizon. Let me ask you this. Do you have a satellite phone? Should communications go down with cell towers? Do you have a satellite phone to get a hold of that college student or your spouse who travels, whatever it might be, to get a hold of your senior adult parents? We have satellite phones at worldviewtalk.com, and you get the satellite phone for free when you sign up for their very reasonable payment programs for the service. Sign up for the service with a reasonable contract, get the satellite phone for free. Worldviewtalk.com. You'll also find they have, well, what I now have, which is a solar generator. Yeah, I have a gas generator, an LP propane generator, but what if that goes down? I want to back up to my backup. So I now have a solar generator as well. You'll find them at worldviewtalk.com. Check it out today, worldviewtalk.com.
And showing that the administration of antivirals more than 2 days post-symptom onset causes more harm than good. The risk-benefit analysis does not correlate.
The moment she went in, they started on remdesivir in the emergency room.
I had written, even before we went in, like, get oxygen, get vitamin C, get all of these different protocols, get steroids, get antibiotics, whatever you need. But no remdesivir, no intubation. And that was the very protocol that they wanted to do.
This is our policy and our protocol, and this is the medicine that works the best.
They immediately put him on remdesivir. And as soon as they put him on that, everything started to go downhill.
They gave me an IV dose of remdesivir every day for 5 days. I got sicker and weaker and sicker and weaker.
As soon as he gets remdesivir, within 24 hours, everything starts plummeting.
The page of his medical shows that he got 2 doses of remdesivir and 2 doses of bursenetib, the generic for remdesivir, in 1 day. So technically 4 doses in 1 day and 2 more the next.
And all his symptoms
he needed oxygen. That's all he needed, oxygen.
Quote, he texted me this: they have to figure out a reason to keep me because his oxygen was okay, his numbers were okay, and the reason was remdesivir.
This was an experimental use product, and I knew that each one of those doses was over $3,000.
Are COVID patients worth more to hospitals when it comes to money? According to Section 3710 of the CARES Act, hospitals are reimbursed by the government an extra 20% for each hospitalized Medicare patient.
So they're incentivizing hospitals to use toxic drugs which kill patients.
Welcome back to the Rob Maness Show. It's Whistleblower Wednesday, and we're publicizing the remdesivir papers that's been broken last week on October 4th by J.M. Phelps of the Gateway Pundit, and he writes for several other outlets, including WorldNet Daily, which I quoted in my opening monologue. And it's all about the deaths. And if you'll bring that chart up for me, 64% of the personnel in these clinical trials that Brad Miller mentioned in the last segment, there are the numbers right there. 64% died that had been treated with remdesivir, and these were in military trials. And my other guest today is Dr. Chrisanna Shackelford. And Dr. Shackelford, when you hear those numbers and you realize that Gilead had been approved to study this drug in February of 2020 for this application. And then by March 2020, DOD is announcing that they've entered a cooperative agreement, a contract, so to speak, with Gilead for an antiviral drug, according to the remdesivir papers that have been published. What are you concerned about there, especially when you put the money into this question?
So let me take it back just a little bit further, and I'll tell you what I'm broadly concerned about and bring it back to the specific issue. Many years ago, I had written a line. It's been echoed since then that, what's happening in sort of our civilian population, specifically with our children in terms of the health care crisis, actually impacts our national security and defense readiness posture. And why do I say that? I say that because we have a population that is so sick now that they're no longer enlistment eligible. So bring it very specifically into this particular discussion with regard to the fact that we have documented deaths as a result of remdesivir within the military population. I've already referred to my concerns about whether or not the Secretary of Defense mandated the toxic exposure. In one of your clips, you have Dr. Pierre Corey, mentioning that there is a known toxicity to this particular drug. So writ large, we have issues of harm to our service members, the deaths of our service members. We have a staggering statistic that says that these are the deaths that have occurred within our military population. We have zero data, as you have both discussed between you and Brad, with regard to the specific clinical trial with our military. We don't know if there was informed consent, and there are just big gaping holes with regard to our defense readiness posture writ large, and of course the harms to our service members. So let me go ahead and add one more nexus to that, which is for those that have quote unquote survived these clinical trials, when they become veterans, as we all are, you're a vet, Brad's a vet, I'm a vet. When we show up at the VA, will the VA acknowledge, number one, the toxicity of the drugs, and how are they taking care of service members that have participated in these specific clinical trials? We have zero window into this particular discussion. And in my opinion, that's a catastrophic number that you just had up on the screen.
Yeah, I mean that number is unbelievable. That the leadership of the Department of Defense would expose military service members and their veterans to a toxic drug like this, knowing that it had already in the Ebola trial, which was several years before this, knowing that it killed 53.1% of the folks that it was given to in that trial. And I'll say it again, regardless of the viral load that the individuals that received the drug in the Ebola trial had, it still killed 53.1%. So that question of why the Department of Defense leadership would expose our people to that drug, it for any reason whatsoever, remains on the table. I don't think it gets answered in the papers, Brad. But one of the other questions that I have about this specific issue is, why did DOD and Gilead enter into this contract for this, knowing that issue was present as far as its fatality rate, and what was driving it? Because the drug wasn't even approved for emergency use at that point. Did they get approval for an off-label use of it? It seemed too new to be in anybody's regular formulary, from what I understand.
Well, it's a great question. And so, you say that you don't know if this is mentioned specifically in the remdesivir papers. And what I would say about the remdesivir papers is that a lot of the data is presented, and then some of it is deliberately left open-ended, for the reader to kind of take the questions that are presented and then hopefully go and do their own research and then realize, hey, there's some gaps here. There's information that we should have access to that we do not have access to. And I'll tell you that when you go through the remdesivir papers, it's meticulously cited. Many of those citations are for online services, so you can just click on them. You can go right to where that information was sourced from, to include the data from the trials that were sponsored by NIAID that are included. And that data is available at clinicaltrials.gov, but again, linked to right there within the remdesivir papers. But back to your question. So what I would have to say, and of course I'm speculating somewhat, but when we look at everything else that happened over the last couple of years, all things COVID-19, there appears to have been a certain relationship between certain governmental agencies like DOD and others such as the FDA. Now, we know that the FDA, before approving a product, we know a couple of things. One, there should be certain scientific rigor that goes into the approval of a product. I mean, there's got to be a thorough, comprehensive cost-benefit analysis that would determine whether or not it makes sense to approve a certain product. Now, we know specifically with emergency use authorizations, those can only be given if there are no other extant therapeutics available. And now, now we understand one other dimension of the demonization of other potential therapeutics such as hydroxychloroquine, ivermectin. We've already mentioned once the cost associated with remdesivir treatments. Well, it's about 1,000 times more expensive than those other therapeutics such as ivermectin and hydroxychloroquine. So I would say there's at least some suspicion there. And I think that we are certainly well within our rights to ask some questions as to what exactly was going on and what were some of the rationales behind the decision making so early on for DoD to so liberally use remdesivir in their treatment protocols.
Yeah, and our friend J.M. Phelps, who broke this story, he writes in one of his articles that Public Law 11592 allows for the FDA to authorize emergency use of an otherwise unapproved medical product if the Department of Defense determines that there's a military emergency involving an agent that may cause imminently life-threatening and specific risk to U.S. forces. It seems to me they needed that time in order to get this EUA approval based on, and the DoD is the only entity in the government in law able to do it. Dr. Shackelford, how many of these clinical trials, Brad cited 5 of them, the one Army sponsored trial doesn't have any data associated with it that's been made public. Are all 5 of these clinical trials, were they all on military people?
So to the best of my knowledge, the short answer is there was in the one article that I wrote, I pulled it up and it said Department of Defense service members and associated federal employees. So there is a outside, I don't have the numbers for how many of those would have been federal employees that may have been able to participate. But again, you have service members in your latest statistic that is still a staggering number in terms of just the use of the military. And again, I go back to this is not an unknown. We have, it's not just remdesivir, although that's the topic of this conversation. It is using our servicewomen for, breast cancer vaccine clinical trials, and the numbers across the board are staggering. And I just keep going back to, and my particular focus is harping on the question of whether or not the Secretary of Defense mandated this toxic exposure, and to the broader Defense Health Agency community. Why did we not have a robust war game, if you will, with our senior leadership when we're talking about global pandemic preparedness with regard to campaign plans? Why did we not bring people to the table that would have said to the SecDef, cease and desist? This is not something we need to be doing to our first line responders, if you will. And yet that did not happen. We know it did not happen. We saw it within the COVID vaccine issue, the gene therapy technology. It simply did not happen. We just had blanket responses that said, use this, regardless of whether or not there were any, as Brad mentioned before, whether or not we had established primary efficacy endpoints that would have demonstrated that an illness or disease would have been resolved. We didn't have that. We saw that in COVID. It was going to be a reduction of symptoms only. When you bring it back to the issue of whether or not the Department of Defense can bring forward a treatment, if you will, that is required because we've got service members going into areas where there are known illnesses and diseases, this product should never have been on the table.
Yeah, you're absolutely right. And when we come back from this next break, I want to talk about the clinical trial itself, that how it's supposed to work. Brad, you mentioned the problems with the placebo part of these trials that are in the papers, and I'm interested to hear about, and I know the audience is too, what the issues were with that, and the reliability of the data that continues to come out about this without the endpoints being adjusted. How can we tell? Is there a way to tell about that? We'll be right back with former Lieutenant Colonel, U.S. Army Brad Miller, and Dr. Chrisanna Shackelford. And we're talking about the remdesivir papers, whistleblower, and the damning evidence in this report. We'll be right back on the Rob Maness Show at Worldview 2.
Remember that in 2018, remdesivir, one of my favorite targets, remdesivir was too unethical to put into Ebola clinical trials in Africa because it had a 53% kill rate published in medical journals. Ebola doesn't have a 53% kill rate, but it was chosen in April and May of 2020 to be the drug of choice to treat COVID. This drug was too unethical to use in an African clinical trial because it was killing 53% of the people that it was given to. And we had Anthony Fauci, Deborah Birx sitting next to the president going, we need to use remdesivir, despite the fact that the World Health Organization said it was unethical to use it. Here's the problem. The problem is, as long as the financial interest that dictates what product is going to be promoted is the one making the declaration of the pandemic, we have no possibility for accountability. We have no possibility for justice. And
welcome back to the Rob Maness Show. It's Whistleblower Wednesday, and we're live on Worldview Tube and our X Spaces simulcast with two incredible guests: a retired U.S. Army former Lieutenant Colonel, not retired, Brad Miller, and Dr. Chrisanna Shackelford, who is a veterans vaccine advocate and has studied these issues around toxic exposure intentionally placed on military personnel before. And Brad, you mentioned the placebo issues with these trials, and that appears to be in the papers when it's highlighted there, linked to this endpoint change or moving the goalposts to make the study look better than it was, so the public wouldn't have a public outcry like what's happening right now.
Sure.
I mean, we killed 601 people out of a little over 900 with this stuff, and that's exactly why. How is a placebo part of a trial like that supposed to work? I mean, they did use one, but the papers indicate that it was not done properly.
Yeah. So let's talk about that for a moment. So, before people say, hey, is Miller a scientist or is Phelps a scientist? We do have to remember a lot of the data is coming from the whistleblower, and a lot of the analysis that is written into the studies that's part of the publication is also coming from that whistleblower, who is in a position to also look at this, with some scientific training. That said, you can remember all the way back to middle school science class about the importance of the placebo and the purpose of a control group when you're conducting this type of experiment. Why? Because you got to isolate what variable you're looking for to give you the result that you're looking for, right? So what happens when you spoil your control group by using something that is either an ineffective placebo or it's a placebo that introduces a variable into the experiment, thus spoiling the results or the scientific rigor of the experiment? So a couple of things happen with the placebo. One, different types of placebos were used as opposed to a true placebo, like saline, for example. If other types of placebos are used, then it could introduce some sort of other variable into the experiment that is not necessarily accounted for. And then that, of course, disturbs the results. Another thing, and there have been plenty of claims that this happened with the clinical trials as well. In fact, some of this comes from RFK Jr.'s book, The Real Anthony Fauci, but he also said that during some of these trials, placebos were used. So a placebo is a type of placebo that is known to be toxic. Well, what happens when you use a toxic placebo? Well, the toxic placebo causes an effect, potentially an adverse effect, in the person receiving it. Well, then that also spoils your results. So the use of the placebos in another way was further degraded because there were not detailed records kept of who was receiving what type of placebo. So were they receiving a true placebo like saline, or were they receiving a potentially toxic placebo like what we call, the placebos? But regardless, what we're seeing is that there was an element of scientific rigor that was not present, and we have to ask if that was intentional in order to potentially skew the results of the overall tests.
Wow, it's incredible. Dr. Shackelford, we also read in the papers that they didn't necessarily control, it doesn't appear anyway, because these are patients that are in the hospital with COVID, but they also had comorbidities that affect the disease and are impacted by the drug remdesivir, like renal failure, kidney failure, and remdesivir causes kidney failure. It doesn't seem like they controlled for that either, but somehow we came out with this, with these outcomes that are published all the time. When I did my research for this, it's very difficult to find a negative journalistic, factual article condemning or raising issues with these clinical trials. They're all positive on the use of this drug to this day. As a matter of fact, as the clips that you're seeing today are all from 2023 or earlier, because there literally is no published information out there resulting in this. So my question is, if that is the case, how big of a bar will we have to get over in order for veterans to be able to do things like have a valid claim for disability, the ones that survived this? And is there a valid claim for the families of the people that were killed by it?
It's a tough question. I'm just going to go back first and talk about the use of, as Brad was talking about, primary efficacy endpoints and how we have actually turned bad news into good news, if you will. And I'll just use the COVID example because it's quicker and cleaner. But we heard early on that it was 95% effective. What they actually should have said is efficacy, and what they're referring to was a primary efficacy endpoint where they actually looked to see if there was symptom reduction. Was your cough reduced? Were you able to breathe better? And they used something called relative risk reduction as opposed to absolute risk reduction. And they came out with a statistic that said out of the 80,000 participants in these trials, 40,000 of them that went through the arm where there was allegedly a placebo, and again, it was a placebo. And they said, see, we had a 95% efficacious result, and that is literally what, in part, the DoD ran with and said, hashtag kill the virus, hurry up and get this particular product. So to your question, this ties into the discussion that I talk about and others talk about, where we are trying to figure out where the VA is going to come down on providing disability compensation for veterans that have been harmed, not just in clinical trials, but from the actual, from the clinical trial, from the drug that they've been using. And we already know, speaking of whistleblowers, since this is a whistleblower discussion, we have the whistleblower that came forward and said within the VA, for the purpose of a toxic exposure, they have said, and this is a standard operating procedure, this is an SOP inside the VA, that there is no such thing as a long-term side effect from a vaccine, and it actually includes the use of other drugs or medications. Well, remdesivir was billed as a medication, was it not? So with that said, And with the whistleblower coming forward that says that the VA is going to disenfranchise every single service member that comes forward with this type of a claim, we have to tie and start stitching all of these issues together. Again, I'm going to harp on the fact that I'm laser focused on whether or not SecDef mandated the toxic exposure, but more importantly, with the advent of the PACT Act, PACT, and the toxic exposure risk activity screening that every veteran is eligible for. If they have an SOP that disenfranchises every single service member, where does that leave our service members with regard to disability claims and disability, and more importantly, disability compensation? And as you referred to, if we've already had service members that have passed, where does that leave the families? And we have a big gap in this particular discussion as well.
Yeah, we absolutely do. And Brad, you mentioned, actually, Dr. Shackelford, you mentioned there might have been problems with informed consent in these clinical trials. That's a huge deal. We've seen that with the COVID-19 vaccine issues with military personnel and those kinds of illegal activities. And Daniel LeMay, the whistleblower pseudonym, they write in the papers that in at least one trial that's numbered in the papers, you can go research it and look it up in the article that Phelps has written here, that they were told there have not been any kidney problems seen in humans who have been given remdesivir. And that's a quote. I mean, that seems to me like it's a really good piece of ammunition for disability claims and wrongful death claims.
Well, again, it's going to be a challenge to bring this forward in an environment where we have a VA that, in my words, is hostile to a veteran when they try to file a disability claim, especially across the board under this umbrella of toxic exposure risks activities. So I think we need to really, really harp on this, continue to tie this to the issue of a national security and defense readiness posture issue. But more importantly, just continue to advocate for our veterans who have been harmed by this.
And Brad, your thoughts on that in the context of the COVID-19 vaccine the illegal mandate, sure, and the after effects? I mean, I always think of young Army soldier Carolina Stancic. I think she was Army, is Army. She has just been devastated physically by that. I mean, this has got to be a major opening for these loyal Americans to get some relief.
Yeah, so I would say two things on that. So one, I think the question that we have to ask ourselves is, when we look at the obfuscation that occurred around the efficacy, but also, you know, the potential harm associated with the COVID-19 shots, now we also have to ask very similar questions when it comes to remdesivir. And were they intentionally hiding data from us? And so the reason that I think it's important for people to understand what's going on with remdesivir is because what it does is it permits us to have a wider aperture when we're looking at everything that happened with COVID over the last, now 4.5 years, So remdesivir is almost another prong in the strategy that was used against us. Now, a second point that I kind of want to elucidate here is, well, what are some potential reasons why? Why would they try to mask remdesivir deaths by attributing them to COVID-19 instead? And I think it's at least worth us asking the question, was remdesivir used to try and make it look like COVID-19 was this, awful illness that was killing a bunch of people, thereby causing more people to go take the shots? And I don't necessarily think that it is a leap in logic for us to at least ask that question.
Oh, you're absolutely right. You beat me to my next question. And the reason why I wanted to ask it is because in the papers, LeMay points that out in Phelps's article, that period of time that we're talking about from March of 2020 to October of 2020, and then the mandate becomes effective when? In November, right? If I remember correctly. So but the last one, like I think the Air Force or one of the services had the line in the sand of early November. So you've got this window from the time Austin signs the order, but going back to March 2020 that year, and you've got these 600 fatalities. It'd be easy to point back to that from November or even October and say, see, you need to get the shot. Look at all these people that have died when really they were being killed by the treatment is what was going on. So when we come back, I want to dive into more about that why on the financial side. And we'll hear from Paul Merrick in some testimony that he gave about that very thing, because I think the financial link is important to understand the why and the pathway that led to this, and will be important in holding these corrupt officials accountable for these deaths. We'll be right back on the Rob Maness Show.
If you look at the 4 independent studies, including the large study by the WHO, it shows the opposite effect. Remdesivir increases the risk of death. Let me say that again. Remdesivir increases the risk of death by 3%. It increases your chances of renal failure by 20%. This is a toxic drug. But just to make the situation even more preposterous, the federal government will give hospitals a 20% bonus on the entire hospital bill if they prescribe remdesivir to Medicare patients. The federal government is incentivizing hospitals to prescribe a medication which is toxic. So it should be noted that remdesivir costs about $3,000 a course.
Welcome back to the Rob Maness Show. It's Whistleblower Wednesday, and we're talking about the remdesivir papers released by a whistleblower from within the Department of Defense using the pseudonym Daniel LeMay. Author and investigative journalist J.M. Phelps has published it, broke the story on October 4th in the Gateway Pundit, and has published it in several other outlets. Even Children's Health Defense has written an article about this, and The Independent has written an article about it. And my guests today are former Army Lieutenant Colonel Brad Miller and Dr. Chrisanna Shackelford, speaking with me about the papers and the technical stuff that's come out in that. And Brad, you mentioned the opening of the aperture is the way I heard it, about how we can now use this as a way to get a wider spectrum and really start diving into this and do an investigation. And during the break, I got a question from an audience member, a retired colonel whose mother died of COVID and the issues associated with all of this stuff. And one of the things that he asked is this an opening or a way providing a pathway when combined with the vaccine mandate issues to dig deep enough into these types of corruption so that we can wind the clock back and really figure it out? Because a lot of people have died of turbo cancers, myocarditis, heart attacks, strokes that shouldn't have ever died. in this issue, in and around this issue of COVID-19, the treatments, the vaccines, and those kind of things? Is that an opportunity? And if so, how might that happen using this set of papers?
Yeah, so I would say the answer to that question is yes. Now, how exactly we do that, that remains to be seen. But I think the first thing we do is we start asking the uncomfortable questions. And I would take that further and say we have got to become more comfortable at asking uncomfortable questions rather than, shying away from the questions that perhaps we prefer not to know the answers to. And here's the reason that I say that is because when we look at what happened over the last couple of years, look at the lockdowns, look at the people who were harmed, some of whom were killed, whether it was, an effect from the shot or from remdesivir or whatever, but others, lost their jobs, or they may have lost their savings, or they lost their place of business. But this was a comprehensive, I'm very straightforward when I refer to what happened over the last couple of years as an op. And so do I think that this allows us to understand more comprehensively the strategy that was used against us? Yes. And in recognizing that, hopefully then we can realize we've got to ensure that this never happens again. And in order to ensure that this never happens again, we have to have a realistic and comprehensive appraisal of exactly what was done to us. If we only understand in part exactly what was done to us, it will be hard for us to kind of shore up the gaps that we have in our own, the institutional gaps that we have in our own systems in order to ensure that this doesn't happen again.
Yeah, absolutely right. Hopefully we can get this guy named Robert F. Kennedy Jr. Into the administration of President Donald Trump when he wins the election to address some of those things. Because, Dr. Shackelford, this is a much wider aperture than just veterans and military personnel. When we're talking about people, especially folks that have died of these turbo cancers, the heart attacks, the strokes, well beyond that population. So it's a large endeavor, but as Brad said, it's one that we've got to investigate further and get accomplished, correct?
You're correct. And my background's warfare. I also don't pretend to be a medical expert. One of the conversations that I also engage in is the issue of whether or not our SACDEF mandated a toxic exposure. We can talk about the COVID shots. We can talk about using our military within clinical trials. We also have to take a much, back up a little bit and say, did other armed forces around the world do the same things to their armed forces? So you can ask the question a little bit more bluntly, which is to say, if the United States Armed Forces were all, quote unquote, vaccinated with the COVID shots, if our armed service members, active duty service members, were used in deadly clinical trials, and other countries around the world were not, number one, mandating an mRNA technology, if they were using a particular type of a product, you can say, did the Iranians, did the Russians, pick another adversarial country, did they do the same thing to their armed forces? And I think it's an incredibly important question, as Brad mentioned, to ask the uncomfortable questions, which actually have a very legitimate basis in bringing these discussions together to the Defense Department and demanding those types of answers, because we don't have those answers. Well, actually, let me back up. We actually have evidence that other armed forces did not use mRNA technology, and you could put some of those armed forces into the category of adversaries. So again, we've got issue upon issue upon issue of accountability, of asking questions about the harms to our own armed forces, the SecDef's involvement in that, whether it was the mandates for the shots, whether it was even allowing our military to be used as guinea pigs in deadly clinical trials. And then again, taking that much broader view, if you will, and looking at how do we develop, if you will, if we were in a war game, we would develop a foresight picture. How would you develop a foresight picture that addresses the harms to our service members, the readiness of our of our armed forces, tie it into, you mentioned Bobby Kennedy, you actually brought in that clip of Dr. David Martin. Both of them have discussed this extensively. Tie that into the broader issues of not just the health of our children and whether or not they're going to be able to even be enlistment eligible in our armed forces, but let's look at all these financial incentives, which is, again, the clip that you brought in of Dr. Martin. All of this ties into feeding into decisions that were made by the Department of Defense. So again, I'm going to take that warfare view of this and ask more uncomfortable questions.
Yeah, that's a key uncomfortable question. Is when you link the financial aspects to this, but that flows from Secretary Austin's decision and whoever was giving him guidance. And we know the President of the United States' view on it is, yeah, I'm going to order him to do it. He wanted to order civilian companies to have to do it, and was defeated in the courts over that. And eventually, Austin was too. Unfortunately, it's too late. These financial incentives were a conspiracy theory for a long time, and that's one of the reasons why I wanted to do this show very quickly after this release by Mr. Phelps and this Daniel LeMay pseudonym whistleblower, is because this breaks a lot of the logjam of the so-called elites saying, it's a conspiracy theory, it's not accurate. The hospitals were being paid more. Significantly more, and we're being incentivized to use remdesivir even beyond the 2 days of initial viral load that the basic nursing student, you've heard her say it twice in these clips, said we were told not to do that, not to use an antiviral after 2 days, and then you combine it with the dangers associated with this drug. Well, we've got a question from our audience, one more question from our audience. Let's go ahead and take that before we close out the show. Our host over there is Shell. Go ahead, Shell, with that question.
With Julie, sir.
Hey, good afternoon. Shaq, Brad, it's Julie 3 out in Butte County. So great to hear you guys. Thank you for your service. This just kills me. I'm fighting this medical tyranny every single day. And to hear that they used our military for the clinical trials of this horrific drug is just outrageous. I'm assuming you guys are maybe aware of the former Feds group and the CHBMP organization that helps the civilian side, the victims and the survivors. I'm on weekly calls with them to support the, again, the survivors of family members that have been murdered with this hospital protocol. But my question, and actually I sent you guys both this press release from Gilead. They just sent 5,000 vials of remdesivir to Rwanda for Marburg virus. So now I think we're actively participating in a genocide over in Africa. So just wanted to throw that out there. You guys got a big platform, and we do need to expose everybody up and down the chain. And I'm going to put the Operation Warp Speed org chart into the bubble. And I think that Ezekiel Emanuel is another name you need to write down who's responsible for this deadly hospital protocol. And there's financial.
And I think we lost Julie, Shell, but we've got enough to. And thank you, Julie, for the question. Appreciate what you guys do. Yeah, in my research on this, I came across you guys in the former Feds. Dr. Shackelford, you want to take your answer for that question first about these 5,000 vials going over to Rwanda, right?
I thought she said Iran, but I was having a hard time hearing her. It's interesting that we're still, again, sending this around the world, that we're actually not just harming our own population, our armed forces specifically. I'm not aware of this particular point that Julie was making. But again, we have, this is a global topic. When we get into global forums where we have this particular discussion, we have members of German parliament. I have talked to members of other nations' armed forces as well. And we have to collectively say, stop, first of all, and then to Julie's point, raise the question, why are we continuing to do this? Again, this is the first heard from me on this particular data set.
Yeah, thank you very much. I appreciate it. Brad, go ahead and in your answer at the end of it, give folks, tell folks where they can find you, and then we'll come back to Dr. Shackelford real quick. We've got about 30 seconds.
Yeah, let me just say, people need to watch what's going on in the military because, it's a captive population, even though you don't lose all your rights when you join the military. But people need to understand that what happens in the military often serves as a waypoint along the trajectory of what's going to happen in society at large. We saw that with the mandate for the COVID shots. perhaps also the use of remdesivir. So people need to realize that. Hey, thanks for having me. If people want to find me, I'm really active on Twitter or X. People can find me at BradMiller1010.
Thank you, Brad. Appreciate it. Dr. Shackelford, go ahead, tell folks where they can find you.
So just really quickly, first of all, thank you for having me. You can find me on X as well, DRC_Shackelford. It's Dr. Chrisana_Shackelford, but it's the DRC. I also have Substack where I've written on this topic extensively called Interdependencies. Foremost, thank you. Thank you for having us.
Thank you both for coming on. This is a lot of information to pack into a 1-hour show and take questions too. So great job, folks. I appreciate it. But go look up J.M. Phelps on X. All the articles are on his X feed, and they're fantastic. There's a lot of information here. We just barely touched the surface, and it's earth-shattering, truthful, factual data and information. I'm Rob Maness. And tomorrow we'll see you on Truth Thursday. We've got the Mississippi GOP chairman, Mike Hurst, with us as our guest. We're talking about elections and everything exposed to that.